There we go. How's that?
Yep,
All right.
that's fine.
All right. So I am sleep medicine research fellow. I did my clinical fellowship 2018, 2019, and I'm very interested in the muscles of the airway and how they relate to sleep apnea. And so a couple of years ago, I asked the question, why do we have a soft palate? And it's let me on this down a rabbit hole of evolution. And I'm going to share some of the insights, what evolution has gained to me, because it's allowed me to really understand the airway in a different way. So, and disclosures, I have no financial entanglements. I have NIH funding via the T32 grant. This is my daughter, Zoe, who was diagnosed with severe OSA at the age of 19 months after she'd already had her adenoidectomy. Getting her tonsils out didn't help all that much. And so this is her airway. This is when you look in her mouth, and I need to understand why the back of her mouth looks like that. So objectives: understand human pharyngeal anatomy from a functional standpoint based on evolution, then talk about what might be going wrong in sleep apnea, and then how might we use these insights to improve sleep apnea treatment. Here's a little plug for this book, Your Inner Fish, by Neil Shubin, because we are all derived from the earliest vertebrates, fish, and they can tell us a lot. All right, so this we've got to start out with what's a normal airway during sleep. So this video is basically a nasal endoscopy video of people during drug-induced sleep. So this was before anesthesia, so they've got a little bit of neuromuscular relaxant on board. And I'm just to give you the anatomy, this is the nase endoscope goes through the base of the nose, and then it looks down. And so you'll see the soft palate and the epiglottis, and then you'll see the walls of the airway. You don't actually see the opening to the esophagus like that. You don't ever see. So all these anatomy drawings, take them with a grain of salt because they're basically all wrong. They're just stylized things. All right, so back to this. So we're looking down, and here's the soft palate up here at the back. The tongue would be around here. Here's the posterior wall of the pharynx. Here are the sides. And you can see in normal, the soft palate is nicely adhering to the back of the tongue. You can see this palatopharyngeal fold. And what's interesting too is that the airway, so during inspiration, it actually expands. You see it inspiration, then expiration, it goes, inspiration, it expands. So your brainstem is programmed to actually activate your airway muscles in anticipation of the negative pressure generated by the diaphragm. And so you're programmed to hold your airway open and actually expand it in normal people, okay? Now, this is what happens in people with sleep apnea. So here we go. Oh, don't tell me it's not going to work. Okay, here we go. All right. Here we go. Now, same view. Here's the posterior wall of the pharynx. Here's the soft palate. And instead of seeing this nicely defined anatomy, you've got expiratory billowing of the soft palate. So it's prolapsing up into the nasopharynx, and it's unrestrained, and you're not seeing this beautiful anatomy that you do during sleep in normal people. And so what's going on with this? So we've got a not floppy soft palate in normals and a floppy palate. And so part of the reason why we have this problem is that we don't understand this is that how we usually think of the soft palate is based on these stylized anatomy drawings. So this is a soft palate right here. And we like dutifully learn the palatopharyngeal arch and back, the palatoglossal arch, but we don't really appreciate that the soft palate muscles are actually span the entire airway from the base of the skull down to the thyroid cartilage, which houses the larynx, and even beyond, further down that into the hypopharynx. And so these longitudinal muscles, you can see they're spanning two solid surfaces, And so these are going to be really important for maintaining the lateral walls of the airway. They're kind of stents for the airway, struts. All right, so how do we figure out all this confusing anatomy? I'm going to start with a terminology review. So first, here is a stylized sagittal cross-section from the skull. So here's the nasal cavity, here's the hard palate, the soft palate, the tongue. The bulk of the muscle is genioglossus, which goes from the hyoid to the chin, genioid tubercle. You have the hyoid bone here. You've got the epiglottis hiding back here. So it's a little cartilaginous flap that will fold over the larynx during swallowing. At least that's what people tell us its role is. We have the thyroid cartilage here, which holds the larynx. Also, the larynx, we'll call it the glottis as well. It's kind of the generic term in comparative zoology. And then we have the pharynx, and the pharynx can be segmented into regions based on where they are. So the nasopharynx is opposite the nose. The velopharynx is opposite the soft palate, or the velum. It's another word for it. The oropharynx is opposite the oral cavity, and the hypopharynx is below the epiglottis and hyoid. And then there are a couple spaces. So one is the oropharyngeal isthmus, which is the passageway between the oral cavity and the pharynx. It's also called the isthmus of Fauces and the glossopalatal sphincter, but I just call it the OPI, oropharyngeal isthmus. We have the nasopharyngeal port, which is the passageway between the nose and the pharynx. And then we have the vallecula. And everyone's like, what's the vallecula? So the vallecula is a space between the tongue and the epiglottis. And this is a very ignored site, which I think is very important, because when mammals chew, the food automatically should get deposited into the vallecula for storing, so that it's stored happily until you're ready to swallow. So this expands your ability to, or mammals' ability to process food efficiently without having to swallow constantly. All right. And so to understand this mess, like how all this works, we really have to understand the basic questions of why do we have a soft palate? Why do we have a muscular pharynx? Why do we have a tongue? And why do we have a hyoid bone? And we recognize these things, but if you really start thinking about it, it's like, why? So I'm going to start first with vertebrate paleontology, vertebrate comparative zoology. So this little beast is an Amphioxus. It's a little tiny chordate that's so small it doesn't need a respiratory system. So this is our earliest ancestors didn't need a respiratory system because they could just exchange gas through their skin. But there are limitations if you want to get bigger. So now you need to develop a respiratory system. So insects develop spiracles, and so they don't have lungs. But vertebrates decided, instead of to expand the skin surface, they expanded the pharynx. And so they developed this expansion of the pharyngeal epithelium into gills. And so this is a jawless fish. This is a very first step up from that little primitive chordate. And this is just a modern day lamprey. And how do they breathe? So they have these gills, and they have these branchial arches. Remember the branchial arches back from embryology? So these are little cartilaginous rods that are between these gills, and they're a basket, and they compress, and then they expand open. And that's how the water is passed over these gills. But these guys are kind of slugs. They can't bite stuff. They have a nasty tongue to chew, to like grind up food. But in order to really do well in food acquisition, you need jaws that hinge. And so now we have what are called gnathostomes. So they have a hinging jaw. And so the earliest one, here's this big jaw joint here, right here. But it can only open by going back that first and second arch here. So now this is the first arch, and here's the second arch. So this is a weak. weak way of opening. And so the hyoid developed because it created a strut against the skull case. And so once you had an attachment of this hinge to the skull case, now you could develop powerful opening. And so these jawed fish had somites from cranial nerves, these occipital somites, so cranial nerve 12 and the ansa cervicalis. So these somites migrated up through all these gill arches to the jaw to provide opening power. And so our tongue and all of this stuff started out as a pump to open this jaw. And this increased the respiratory and feeding capacity. And so just to give you an idea, here is a dogfish. And so he's breathing. So he's creating the suction and then he's pushing it across his jaw, his gills. And this allowed them to feed, these fish to feed better. So here are just suction feeding in fish. And it's kind of fun to watch. Like, man, their whole hypobranchial or the hyobranchial apparatus just expands open. Here they go. And this last one's the best. That's pretty cool. One more. Here we go. Look how big that can open. So that's how, this is what our tongues were before we became land animals. Now, this was the big thing that really blew my mind, is that lungs actually evolved for fish initially. Like, we always think, oh, fish grew lungs so they go on water. Actually, a lot of fish need rudimentary lungs because if they're in a low oxygen environment, they will gulp air. And so this is a betta fish. If any of you have had betta fish, they gulp air at the surface. And so they developed an outpouching of this shared gut respiratory endoderm. And because the endoderm, this gut is innervated by cranial nerve 10, that's why our glottis is innervated by cranial nerve 10 as well. And so this allowed for a tight coordination of breathing and swallowing. And they needed to do this so that they didn't flood their lungs. And so they had this pulse pump mechanism. So here's a fish, and here's the glottis. And so they'll go to the surface, open the mouth, expand this hyobranchial cavity with sternohyoideus. And then they'll open the glottis, compress this lung here so that they can exhale with the mouth still open. Then they'll close the glottis, close the mouth. Open the glottis, close the mouth, sorry. Close the mouth, keep the glottis open, and then compress this buccal cavity and pressurize the lung, and then close the glottis. So that's fish lung breathing. And so we've all seen this when we see frogs. It's the same mechanism, except they now have a nostril that they don't have to open their mouth to go to the surface. And so this is the same thing that they're doing. And it's interesting, humans can learn to do this. So paralyzed people or people with neuromuscular disorders can learn this glossopharyngeal breathing as well. But it's inefficient. And amphibians can get away with this because they can breathe through their skin as well. So their skin is still a very significant respiratory organ. But if you wanted to go have horny skin so that you could be away from water, you needed a new respiratory method. But I'm going to talk about feeding, because if you can't suck food in, you need a different way of obtaining food. And so we all have seen this. So now that hypobranchial pump has been transformed into a tongue. So all these muscles that used to be expanding this to create suction now are pushing this tongue out to create the tongue. And so reptiles, as I alluded to, And to stay away from water, they needed to develop a different respiratory organ, which is more efficient. And they also, their tongue can't do double duty as well either. And so they recruited even more distal somites to expand their rib cage. So they developed an aspirational pump, which you can see here. Problem with the aspirational pump that's using these muscles is that it's the same muscles that power the shoulder girdle. And so the chest and the limb girdle are doing double duty. And so reptiles can't breathe when they run. So they can run very fast for short distances, but they can't breathe and run at the same time. So that led to the diaphragm. And so diaphragm offloads these upper chest muscles. And instead we have, diaphragm innervated by cranial nerve, 3, 4, and 5, keep the diaphragm alive. It's a whole nother story how that ended up down here. And I tried to find a video on the mammal breathing, and all I found were all of these things. Everyone talked about, gee, you have to learn to breathe with your diaphragm. And I'm like, why do humans have such trouble breathing with their diaphragm? There's a recurrent theme of this that is worth noting. But anyway, so we got a diaphragm, and that's how we ended up with these highly aerobic endurance runners, which are mammals and marathons. And I'll get back to the horse, because the horse is really lungs on legs. But the diaphragm is what allowed this dense lung tissue to expand, to increase respiratory capacity. And so we needed this high respiratory capacity in order to become warm-blooded, so we could burn our food fast. And so I'm going to talk a little bit about warm-bloodedness and early mammalian evolution. So this guy is a cynodont. So it's an early tetrapod, meaning 4 legs, egg laying, and seems to be on the way of becoming a mammal. But the problem is, when you're warm-blooded, you need to feed your young, because their surface area to volume ratio, they just cool down fast. So you need to feed your young. And a great food source was what this is. So this is milk from an echidna, but it actually came from sweat. So it's sweating. So the echidna just sweats milk, and the babies lap it up. And so milk actually comes from there's a mutation in lysozyme, which is an enzyme that's used for antibacterial, that's an antibacterial properties. And it was used to slather on these eggs to keep the bacteria at bay, turned into lactalbumin, which is baby food. And so this became a source of food for the young. Now, something interesting, you can think here, this is a blue-tongued skink. And so they can lap this up. But there's a problem for this as a feeding method with you just lap things up. And I will show you why this is a problem. So here is a thirsty little gecko, this cute video. Well, it's a leopard gecko. And just watch what happens when this gecko tries to drink. So imagine this is a baby cynodont trying to drink its milk. And so it does this for a long time. It does this for like 10 or 15 minutes or 5, 10 minutes. Why? Because this pharynx is not well designed for drinking. So this is a turtle, stylized turtle, and it has no pharyngeal wall muscles. So its pharynx is just epithelium on bone, basically. And then you've got the tongue and the glottis and the hyoid. These guys are in close association, but has no way of controlling liquids. All it has to do is keep the tongue out of the airway at night, but it can't it can't control liquid, so it has to hold the head up to let everything drain before it can safely open up its glottis, because if there's anything here, it's gonna get water in its airway. And so reptiles are, their pharynx is designed for swallowing solid chunks by what's called pharyngeal packing. And so I colorized this drawing. So this is another turtle. And so cross sections of the turtle, and I colored in the tongue in pink, and this bolus chunk of food is this black, and then here's the hyoid bone. And so the turtle moves this chunk of food to the back of its mouth, and then it gets the tongue in like behind this chunk of food, and then those infrahyoid muscles just pull that all down and stuff it into the pharynx. So it has a different method of swallowing than we do. So because we have a muscular pharynx, which was evolved to deal with liquids. And so this is a dynamic MRI of an adult human, which will show you how we swallow liquids. And so just to give you an idea. So this is the tongue, and then here's a soft palate right here. The hyoid is right here. Epiglottis is here. And then here is the thyroid cartilage, and then here's the glottis here. Here's your spine. Okay, so I'm gonna watch this. So now I'm gonna turn this movie on so you can watch. This is some pineapple juice, which has like a nice, it's seen well on MRI. And there you go. Now I'm gonna have you draw your attention to the soft palate right here. And so watch what the soft palate does. You see that? The soft palate closes. So now you're keeping the fluid from going up into the nose. Okay, and now pay attention down here to the glottis. What happens here? Do you see that? So the glottis is pulled up and forward. And so the glottis is protected by the base of the tongue. So this is how we swallow. We close off the nose and then ram the glottis up underneath the tongue to keep it from getting fluid into it. And so this is why we have this muscular pharynx. And these longitudinal muscles that take care of this pulling up are really, really important. And so the biggest one that seems to be important is Palatopharyngeus. So this is as big muscle as a soft palate that extends here. So here's our cross section through, and they've taken a lot of muscles out. This is from Netter, and then I drew on it. So here's from the soft palate, and it comes down, and it inserts into the hypopharynx down here, but it also inserts into the thyroid cartilage, and it also inserts into the epiglottic fold. So it controls that space around this vallecula. And so there's this longitudinal portion that elevates the larynx, shortens the pharynx. And then there's also a transverse portion that Netter doesn't draw in because, well, it was only described in 2012 by these Japanese anatomists, Sumida et al. And that helps to close this nasopharyngeal port. And now there's another longitudinal muscle of the pharynx. Oh, actually, let me go on here. So one thing to notice that's important is that in order to elevate this larynx, you need to have a potential space. So all this stuff is movable. So this whole muscular pharynx is actually only attached to a couple spots. So it's attached up here at the pharyngeal raphe. And then we have these soft palate muscles here. So we've got levator veli palatini, tensor veli palatini off to the side. We have an attachment at the here at the end of the soft palate. There's an attachment here, and then on the mandible there's another attachment for the superior pharyngeal constrictor. But this whole area here is open because we need this mobility to move the larynx up and down. And so the question is, if you have all these muscles and you can be creating negative pressure in here when you breathe, how do you keep the muscles from falling in? So there's another longitudinal muscle right here called Stylopharyngeus. So the styloid processes are these guys here. I got my styloid process. Little guys here at they're kind of lateral and behind the airway. So they're not on the sagittal plane. Here we go. And so the Stylopharyngeus comes down, it inserts between the middle and superior pharyngeal constrictors and actually interweaves with the middle pharyngeal constrictor. And then it travels further down, joining up with Palatopharyngeus to have fibers going into the same places. So the thyroid cartilage, the epiglottic fold, and the hypopharynx. And so Stylopharyngeus is also innervated by cranial nerve 9, which is a glossopharyngeal nerve. So it's the only pharyngeal muscle that's not 10. And this is interesting. So cranial nerve 9 also is innervating the carotid body. Interesting. Okay. So there's some great experiments in horses done by Susan Holcomb, who I tried to get to come and talk to us because her experiments were fascinating, but she didn't want to come. But so she did all these experiments in horses. So like I said, horses are basically lungs on legs, and they can generate massive amounts of intrathoracic pressure. So they can have intraalveolar pressures in the -100 when they're like thoroughbreds are racing. But if that's in the intraalveolar, that's not up here. And so the horses have Stylopharyngeus. So they have a different hyoid apparatus. They have their styloid actually comes all the way down. So their styloid process goes all the way down to the tongue. But Stylopharyngeus comes down off this long styloid and it inserts into the muscles of the pharynx, just like ours does. And so this view is a little different from the ones that I showed you with the sleep. But it's the same idea. They're going through the nose, you're looking down, and here's the epiglottis, here's the glottis, and here's the posterior wall of the pharynx. It's just flipped around. And so the horses, you can access Stylopharyngeus by doing a nasoendoscope. You can kind of go around, and you can actually you can knock out the glossopharyngeal nerve with some lidocaine. And so she did those experiments. And first, when they locked out the glossopharyngeal nerve, the first thing they noticed is that the horses could still swallow pretty well. It didn't really bother them. So that means that the Stylopharyngeus doesn't have a whole big role in swallowing. It's really Palatopharyngeus. You knock out cranial nerve 10, the animals can't swallow at all. And Palatopharyngeus is innervated by 10. So now I'm going to show you, this is its nasoendoscope view. This is no anesthesia. And so here's the posterior wall of the pharynx. Here's the larynx here. Here's the epiglottis. And these little divots here, that's where the Stylopharyngeus, they can actually see where Stylopharyngeus is inserting into the pharyngeal wall. And so these are running horses. So these are horses that are running on a treadmill, and she's sticking this nasoendoscope into their nose. And then when she does bilateral anesthesia, look what happens to their pharyngeal wall. It's collapsing inward on inspiration. So you've now lost, you can't see the back of this thyroid cartilage here that you can see here. And all these divots are gone. It's falling in. It has no effect on exhalation. It's only on inspiration that you see this. So, interesting. So what does Stylopharyngeus? So now we're gonna go into some of the human stuff right now. So Stylopharyngeus in a dissected human. Here's another Japanese anatomist. The Japanese anatomist, if you're interested in this stuff, you need to read all these Japanese anatomy papers because they've got the best here. So here's Stylopharyngeus dissected out in a human with a posterior view. So here's the pharyngeal raphe. Here's the superior constrictor, middle pharyngeal constrictor, and here's Stylopharyngeus snaking down in between the two. And then here are these soft palate ones. Okay, so when I saw this, I was like, this reminds me of something. And what it reminded me of was airway shapes in people with sleep apnea versus normal. So this is taken from a Schwab paper back from 2003 where he did 3D imaging and then made reconstructed images of what the airways look like. And so here's normal. You see a wide, so this is retropharyngeal. So this is the retropalatal airspace. This is the retroglossal airspace, so RPRG. So this is basically oropharynx, nasopharynx. And in people with sleep apnea, this retropalatal space is all spread out. And I'm just like, look at this. Doesn't that look like Stylopharyngeus is working here, but not doing here? And instead this whole thing is falling down. Just saying. So then I'm thinking about airway shapes. So the forces to create these airway shapes. This is another Schwab paper where he looked at, these are transverse sections through the airway. And so people, normally, if you like cut them here at the neck and you look down to see what their airway looks like, and so this is the AP is going this way. So here's front, here's back, and the sides. The normal airway is elliptical in a lateral direction. We found snorers are more circular. And people with sleep apnea are elliptical in an anterior-posterior direction. And so if you wanted to, so if you want to just think of it as an airway here, I added this little pharyngeal raphe to show that this is the back. So you could create this airway shape by pulling forward on the sleep apneics and by pulling laterally on people who are normal, right? That's how you create these shapes. So you can play around with the vectors and like, well, you can create these lateral forces by having a force from genioglossus and a force by that Stylopharyngeus. Just spitballing, but it really seems to explain this airway shape, that Stylopharyngeus is going to be just vector-wise implicated in airway stability and is a difference between the two. All right, but let's go on. So here we have our early mammalian evolution, and we've got to have the question of like, well, why not just suck directly? Now that we have a muscular pharynx, why would you not just suck directly? Because if you suck directly in that on this maternal milk ducts, you end up with hickeys. And if you keep doing this, bad things happen. You end up with the sore nipples like that. And this actually happens. And this is a bad evolutionary strategy, and that infant would not live to reproductive age without an artificial nipple. So the solution for evolution is the development of the soft palate and suckling. So this is a drawing taken from Professor Fuzz Crompton's website. He's a paleontologist over at Harvard. And this is a cross-section, sagittal cross-section through a possum. And so here's the nasal cavity right here. Here's the brain. And the nasal cavity comes down through here and goes, this is the larynx right here. And this is the soft palate. So actually in non-human adult mammals, this larynx actually goes right up into the nasopharynx. And so it's what's called an intranasal larynx. And so airway is nice and stable through that. So for suckling, here is the nipple, here's some fluid in here, here's the tongue. And what he's found is that this suckling occurs by bringing the back of the tongue up, and the middle of the tongue goes up and down and creates this gentle local suction. And the way that the animals create this high posterior tongue position that allows this to happen is by tensor veli palatini, which is the muscle of the soft palate, which comes from this pterygoid hamulus, hangs around here, and then a muscle in the tongue, or a muscle of the soft palate that inserts into the tongue, then comes up and it hoists this posterior tongue up. So it creates a seal in the back of the mouth. Middle here creates the local suction. And so then you have the pressure gradient going all the way along the tongue instead of just along the lips. And so breathing can be maintained during this. And so this is suckling, and this is why we have a soft palate. And if you think that's crazy, well, here, this is a baby who's sleeping and dreaming of suckling. And that's that up and down movement of the middle of the tongue. So this is normal. This is what we should be doing to create these movement patterns. And so why is this important? How does this relate to sleep apnea? So this posterior tongue position is really, really important because it will interlock with the soft palate. So this is just show you the sequence of events that happen in normal human swallowing. So here's a barium bolus in the mouth. Normal, you start with this oropharyngeal isthmus closed with this high posterior tongue. And then when you initiate the swallow, the posterior tongue drops down. Oops. And then the soft palate swings up to close this nasopharyngeal port. The hyoid moves forward. The larynx moves up like I showed in that video. And then this bolus passes into the esophagus. But this doesn't quite happen normally in people with sleep disordered breathing. So not just sleep apnea, but people with snoring. So this is a study that was published almost 20 years ago by some Swedish dentists who suspected swallowing issues. And they found, interestingly enough, that even before swallowing, there was a problem. So they put the barium in the mouth. They couldn't keep it there. And so instead it's falling down. And so here it fell into the vallecula, started coming out like right above the larynx. So instead of having this nice bolus in the mouth with this posterior oropharyngeal seal, they can't make that seal. And this happened, and here it's leaked past the vallecula. This happened in 50% of people with sleep disordered breathing, regardless of AHI. And this is just lateral cephs with barium. This is not really sensitive for finding differences in the muscles. This is a big functional thing. And these people weren't complaining of swallowing problems. And yet there was something really funky with their swallow. And it's really this deficient closure of the oropharyngeal isthmus. And so now this makes you wonder back at the sleeping stuff. So if you have a poorly closed oropharyngeal isthmus while awake, maybe this is why you have a poorly closed oropharyngeal while asleep. And indeed, there is something fundamentally funky with this swallowing mechanism. So these are functional MRI images taken from normals and people with sleep apnea. So functional MRI is a method of monitoring blood flow in the brain. So you can look at brain activity. The more active an area of brain is, the more blood flow is. You can detect that with MRI. And so you take a bunch of MRIs, you group them together, and you can get an idea of what areas of the brain are important for different activities. And so this is a study done by Sai Parthasarathy's lab back at the University of Arizona. And they had people dry swallow in the scanner. And they had controls, and interestingly enough, they found differences at the nucleus ambiguus. So here's a nucleus ambiguus in the normals, in the control subjects without sleep disorder breathing. And in the people with sleep apnea, it didn't light up at all. And so what's important is that the nucleus ambiguus, this is the motor nerve center, or the brainstem center for cranial nerves 9 and 10. So these are the muscles of the soft palate and the pharyngeal muscles. And for whatever reason, these aren't being activated during the swallow. This is the mammalian swallowing mechanism that isn't being used. They're using they're using a different mechanism to swallow. I think this is really, really important. There's something different about the swallow, and we need to figure this out, because we need to be able to control these muscles to keep them maintaining tone during sleep. And so
what was the interpretation that they had of their findings?
Their findings, they didn't think about it. So they were only interested in this is caused by subclinical hypoxic brain injury. That's how they were interpreting this. And I was like, you don't have pinpoints subclinical brain injury. That's not a stroke. Those aren't many strokes. And that these were young men too. They purposely looked at young men to avoid that. And they used that conclusion. I was like, guys, you're wrong. They're using a different swelling. And what's interesting, they noted that the cheek muscles were lighting up when they swallowed. In the people with sleep apnea, they were using their cheeks to help them swallow, which blew my mind, because that's actually something that myofunctional therapists specifically try to detrain. So they force people to swallow like this to keep your cheeks active like that, so it can't participate in the swallow. So this is this aberrant swallow that people with myofunctional therapy are targeting. And so indeed, here is this study, which, published back in 2009, the Guimarães study, showing that myofunctional therapy can treat sleep apnea to a degree. It can improve sleep apnea. So this was a trial, a 3-month-long trial with 30 minutes of daily exercises. It's like a lot of effort with people with moderate sleep apnea. And after 3 months of exercises, their AHI went from a mean of 23 down to 14. Most people showed benefit from it. So their control group didn't really change. But I think we can do better, because honestly, with all the stuff that I've studied, I don't think that the swallowing technique that's targeted in myofunctional therapy is exactly right. I think there's more to it than that they're teaching. But the myofunctional therapy does focus on figuring out that closure of the oropharyngealism. But I think we can do better than this. But so we don't have this to offer just yet. I'm working on it. But what else can we do? So I'm just going to throw a couple sleep apnea things in here. Is mouth tape. No one wants to talk about mouth tape, but I think mouth tape is effective, because remember that little fluttering soft palate? If you're letting air go through your mouth, you're worsening that fluttering, the soft palate. And that fluttering, moving between oral breathing and nasal breathing, is always associated with an arousal. And so here was a quick study, a small study that was published back in 1999 of people on BiPAP. Most of them had COPD or kyphoscoliosis, and just putting mouth tape on them improved their arousal index significantly. So they ended up having an arousal index, 40-ish, and they went down below 20 as a mean. And then we all know, like, full face masks suck. I love to emphasize this, because people still don't know. Most people are getting it now. But so people with so here is a study, it was a case which showed, here we have our REM sleep, here we have supine. And so every time this person got supine, they had a whole bunch of apneas, and this is with a full face mask on a CPAP of 10 with a residual AHI of 10, a CPAP of 16 with a residual AHI of 10. Put them on a nasal mask, and so that you're not forcing air through that oropharyngealism, now you can control their sleep apnea with an AHI of 0, residual obstructive AHI. Even though they're supine, there's no more events. So you really need to keep that oropharyngealism closed, so that you keep that soft palate from flapping around in the airway. So sort of evolution cliff notes. So the hyoid bone supports your jaw, so you can open it with power. It's also the posterior base of the tongue. It has a role in swallowing, glottis positioning. The tongue is a feeding tool derived from a pump. The muscular pharynx is required for safe swallowing of liquids. So that's why people with dysphagia, they all get their thickened liquids. And then the soft palate evolved for suckling. And now the closing points for sleep apnea. Soft palate and the longitudinal pharyngeal muscles play a critical role in airway stability. Subclinical swallowing dysfunction is seen in 50% of sleep disordered breathing by modified barium swallow. And so there's dysfunction of neural control of swallowing at the level of the brainstem that's seen in sleep apnea. And so understanding and correcting this dysfunction, I think, is going to be critical for treatment and prevention. And that's a strengthening. Strengthening is not enough. So any sort of exercise protocol that focuses only on strengthening is not going to wake up your brainstem. So strengthening is not enough. Okay, that's it. And thanks to Dr. Stroll, who's Mr. Miyagi. All right.